Hello, I'm Constantine Tam from Melbourne, and I'm here with my good friend Alessandra Tedeschi from Milano. And we are in Edinburgh for the international workshop for chronic lymphocytic leukemia. So, Alessandra, we've now 3 days into the workshop. What have been your highlights for you so far?
A lot of interesting things. We are changing our approach to CLL, I think. We are still aware that we are not curing our patients. I'm sorry for this, but maybe in the next workshops we will see more combination treatments and more MRD assessment to arrive to something better and deeper for our patients. But I think we are doing well.
Yes, I mean, for me, the whole theme of combinations and MRD negativity and trying to get patients off therapy seems to be a big theme in this workshop. But perhaps you can tell us about your work first on the Resonate 2 update.
I am not a fixed dose person. I didn't present something on fixed dose. I presented the 2 studies, ibrutinib based for the elderly, ibrutinib obinutuzumab versus chlorambucil obinutuzumab, and the update of the Resonate 2 trial. Ibrutinib obinutuzumab was a trial designed based on the comparator arm, as chlorambucil obinutuzumab was considered the standard of care in the elderly population, so it was normal to make such a comparison. Of course, ibrutinib obinutuzumab did better, and importantly, even in the high-risk population. And this was the first trial addressing this issue in the high-risk population. Now, I don't really know if we need to add obinutuzumab to ibrutinib. This is a big question.
That is a big question, isn't it? So, firstly, whether you need to add an anti-CD20 to ibrutinib, because as you know, both the MD Anderson study and the Milan study show that there was no benefit, addition of rituximab.
Yes.
But you know, perhaps there is. We don't know whether obinutuzumab, is the same or different. So you did your 2 studies on chlorambucil versus ibrutinib, Resonate 2, and then the follow-up, which is chlorambucil plus obinutuzumab versus ibrutinib plus obinutuzumab. And in both studies, the ibrutinib-containing arm, came out on top. So I guess a big message from that study, those 2 studies, is that ibrutinib is a preferred treatment for older patients in the front line.
It's preferred treatment in front line, prolongs progression-free survival, and it's very well tolerated. I mean, if you look at the safety profile of the long-term follow-up, we don't have new side effects with a 5 years follow-up, and most of the adverse events were in the first year. So even discontinuations and dose holding were most frequent in the first years. So if you go through the first year, the treatment is very well tolerated. The patients remain on ibrutinib for a long-term period.
Yeah, I recall that I think the median time of therapy was almost 5 years, at 57 months.
5.5 years, yes.
So your average frontline elderly patient is taking 5 years of ibrutinib with good outcome. And for patients who remain on drug, the rate of progression on drug is very low at 8%.
Very low. It's 6%.
6%,
only
right.
8 patients progress. So the number of events is very low. And for this reason, it's impossible to compare the ibrutinib obinutuzumab with ibrutinib, because you don't have so many events to say if it's better ibrutinib obinutuzumab or ibrutinib, although the population were different. But it's different to compare the two arms.
It's a nice problem to have when both arms are doing so well that you can't compare the difference.
Yes.
What do you think about the alternate approach with the venetoclax? Because the CLL14, which is same control arm, chlorambucil plus obinutuzumab versus venetoclax obinutuzumab. What are your thoughts on CLL14?
Well, it's a fixed dose, so theoretically should be better, at least from a cost point of view, which is in our European countries is very important. I need I think we need longer follow-up to understand really which will be the outcome. And maybe there are some particular population that don't benefit so much from venetoclax or inotuzumab. Just look at 70p deleted patients. I think that in this case, maybe BTK inhibitors perform better than a fixed dose of venetoclax or inotuzumab. Maybe you have more experience than me with venetoclax, so...
Yeah, I mean, there's no head-to-head evidence, but the 17p arm, you know, with the caveats, the comparative parent study, 17p arm on the CLL 14 did look a little bit disappointing with venetoclax plus obinutuzumab, albeit few patients. Yes. And the frontline ibrutinib study seemed to show more stability with 17p. And I guess that brings down the question of fixed duration, but MRD positive, isn't it? Because yes. We know that part of what the venetoclax combination relies on is to achieve MRD negativity and get the patients off drug. And then there's a question of, well, if you have your 2 years of therapy and you're a high-risk patient, like a 17p patient, or you're MRD positive, are you really safe to come off drug? And that seems to be a recurrent question amongst the audience. And I guess the answer now is, well, you have to, because that's the way the study is designed. But further follow-up would tell us, whether that's a good thing or bad thing to do to stop venetoclax, in a high-risk patient.
And then we have the other issue of salvage treatment. Yeah. We know how venetoclax perform after ibrutinib. We don't know how ibrutinib performs after venetoclax, or even if we can retreat patients with venetoclax.
Yeah.
So all these problems should be solved maybe in the next international workshop.
I think so.
Yes.
But maybe talk about MRD, because that seems to be a fairly big topic as well.
Yes.
Maybe you can provide a bit of background to the audience as to what the MRD discussions were.
Well, MRD, most of the studies now rely on MRD. And in my thoughts, maybe studies addressing MRD and starting treatment according to MRD relapse, yes or no, may be more important, because what we are doing now, we are just searching MRD, and now on the basis of this MRD, we are not doing anything. See the CLL 14 or the Murano study. I mean, it's just a study on MRD, but we are not doing anything. While we have a study ongoing, which is a Captivate study, in which we are doing a treatment MRD oriented, and maybe we are moving towards this direction, I think, in the future. Although MRD is something very difficult to do by all the centers. I don't know how it is in your country, but maybe in Italy, only the big centers will be able to assess MRD, and to harmonize MRDs, I don't think it's so simple to do.
Yeah.
So
I think you're right, isn't it? Now at the moment, when we get MRD negative result, we feel better, but we don't change our management based on the current treatment. There's a lot of discussion about what should be the right threshold. So at the moment, I think everyone agrees that, flow cytometry at 10 to negative 4 is a accepted threshold, but now that we've got better at what we're doing, we're now talking about is 10 to negative 5 better, is 10 to negative 6 better, is high throughput sequencing better. So there's a lot of uncertainty and discussion about whether going deeper and with new technology is better. But for me, the big message is flow at 10 to negative 4 is still the way to go.
Yes.
And it seems to me that the big message is that if you can't get MRD in your center, using the current treatment, it's not a disaster, because the current venetoclax therapies are fixed in duration.
Fixed duration, yes.
You don't ever get MRD clearance on ibrutinib anyway.
Yes, of course.
And so MRD doesn't change clinical decision, but...
So in this moment, it's just a matter of, speculative matter of clinical trials, but it's not changing our clinical management of patients, for sure.
But you're right, I think the next generation of trial will have to incorporate MRD to not over-treat patients who don't need to be treated, and for patients who are MRD positive to potentially intervene and improve the outcome.
Yes.
So that's really interesting. What do you think about the discussion about the standard practice, the discussion about standard staging and what tests should be done at baseline, 17p, mutation sequencing, RGVH? What do you think about the discussion?
So you mean the starting treatment sooner?
Yeah. Oh, no, not starting treatment sooner.
Sorry.
That the standard workup with the new iwCLL guidelines.
Okay. Well, I think it's a good thing to study all the patients.
Yeah.
We are doing it even if patients don't need treatment, but I know that this is in clinical management, normal clinical management is not...
So what are you doing for your CLL patients at
We
diagnosis?
do everything because we are a referral center, so at the moment the patient arrives, we do all the workup. But
so you do FISH for 17p,
yes. We search everything.
Next generation sequencing for p53.
We are still a rich country in a way, and we are a referral center, so we can do it. But no need to do this thing in clinical practice unless you have to start treatment, I think. Yes, if you have to start the treatment, of course, you have to do all the workup for your patient. So 70p deletion, mutated status, and FISH, of course.
So I think for our audience, what we did was the discussion was that RGVH mutation status should be done at least once in most patients.
And it doesn't change. So
it doesn't change.
You do it once and you have it there. And this changes our treatment approach in patients in this moment, according to the 3 trials we presented today with ibrutinib. So in unmutated patients, you have to think about ibrutinib in this moment rather than immunochemotherapy. Yeah. So you have to do it once, and mutational status, it's okay, it's fine.
Whereas 17p deletion and p53 mutation can be done at the time of first therapy.
At the time of first therapy.
And probably with each subsequent therapy, it would seem because of the clonal evolution.
Yes, of course. But maybe if we start to use a lot of ibrutinib, maybe at the end we won't need to perform the 70p deletion. It will be informative, but maybe for an allotransplant, if we don't have any other thing to do to our patients, because I don't see CAR-T coming so fast in our world in clinical management of patients. We still address some patients to allogenic transplant after having failed the inhibitors.
So you're still doing allogenic transplant for inhibitors?
For young patients failing the inhibitors, yes.
I see. Well, I mean, if we take a step back at the p53 assessment, what surprised me was when they took an audience vote and 80% of people said they do both FISH for 17p and sequencing for p53 mutation at treatment, and that's a much higher percentage than I would have thought, because in my country, my center can do that, but most of the other centers cannot do sequencing for p53. And I guess maybe it reflects the audience that was the workshop.
I think yes, but I think in the last year something changed in this issue. We have ibrutinib. It's not ethical to give another thing to a 70p deleted patients, so the workout should be done.
There's a whole session devoted to resistance mechanisms to novel inhibitors, and for me it was the fantastic talks from Jan Wyack and Marianne Anderson on BTK and BCL2.
And they're very interesting. I mean, I think that seems normal because lymphocytes are very intelligent, and it's not like chronic myeloid leukemia. Someone's always when speaks about CLL and ibrutinib says always it's like chronic myeloid leukemia, but I don't think it's the same disease. Lymphocytes are more intelligent, and under the pressure of ibrutinib, of course, you can develop BTK resistance. We are hoping in this new generation BTK inhibitors like vecabrutinib with non-covalent binding that may overcome the resistance. And the other thing that was very interesting was the venetoclax resistance. And she well showed the two difference between patients progressing immediately and patients progressing after some years for development of mutations. And that I think that this issue with venetoclax will change, because if we give fixed dose of drug, maybe we won't have the pressure of the drug, and we will see less frequently those alterations or those mutations. But with BTK, I think this is a real problem. At one point, the lymphocyte is waking up and changes the BTK.
I mean, with maturity time, we now know that at least half of patients who progress on ibrutinib will carry a BTK mutation,
Yes.
with or without a PLC gamma mutation. And looks like about half the patients who progress on venetoclax will carry a BCL2 mutation. So I guess for me, right, the next question is, should we, we're going to bring this into the clinical testing, and already I found that I'm using the BTK mutation testing to help me make decisions when patients, have unexplained cytopenias or don't seem to be doing so well after a number of years. For me, we know these mutations precede clinical resistance by up to a year. So I think it's nice to identify this mechanism so you can actually confirm your underlying impression that there's an impending relapse coming.
Yes, but at the same time, I think we are not ready to discontinue ibrutinib based only on the presence of the resistance.
Yes. No, you're right. I mean, because we know that people can have the mutation for quite a long time.
Because sometimes clinicians may be scared and change immediately treatment, and still we don't have so many treatments, so we have to keep our patients with the drugs we have in this moment, and when they progress we start a new treatment.
Yes, indeed.